more serious, a professor of neonatal perinatal medicine is urging medical professions and politicians here to reconsider how we treat babies with chromosomal abnormalities. Dr. Marty McCaffrey is a neonatologist visiting from the University of North Carolina to address Stormont about the issue, and he's with us in studio. Dr. Marty McCaffrey, you're welcome to the programme.
Thank you, Pat.
Now, the idea is to talk about the treatment of trisomy 13 and 18, but that's very arcane science to most people. What are these abnormalities?
Sure. So trisomy 13 and 18 are descriptors for basically what is a chromosomal disorder. Many people may be familiar with Down syndrome, which is trisomy 21. That's 321 chromosomes. Trisomy 13 and 18 are 313 chromosomes or 318 chromosomes. All of us, if we are so-called quote-unquote normal, have 46 chromosomes. So these children have 47 chromosomes, either an extra 13 or an extra 18. That extra chromosome creates a potential host of medical problems.
When you say potentially can give rise to a host of medical problems, are some people with those extra chromosomes untouched by difficulty?
No. So they're all touched by difficulty. But the difficulties vary. So that's why I say potential. So if you look up these problems in a medical textbook, there is a list of potential associations that can occur with these problems. They range from heart problems to lung problems to other associated problems with the bowels. They range to brain problems. All children with these disorders are not equally affected. What is common among most of these children is that developmentally, they all are generally pretty severely affected. So these are children who reach developmental ages over time that are not what anyone of us would necessarily want for our children, but they do develop, but they reach developmental stages that approach 2 to 3 years of age.
Now, the diagnosis of these conditions, is it done in utero or is it done subsequent to birth?
Sure. This condition is diagnosed in a number of ways. It is diagnosed both pathways that you described. So we see a fair bit now of antenatal or before birth diagnosis now, either through ultrasound or other types of testing that we do. But a large number of these cases are also diagnosed afterwards. And it sets up an interesting distinction in these babies because when babies are diagnosed before birth and they're diagnosed after birth, their outcomes are very different.
What kind of outcomes? If a baby is diagnosed with these conditions in the womb, is termination often the outcome?
Correct. So what has been seen is that if you have a prenatal diagnosis, before birth diagnosis, and a postnatal diagnosis, the children who are diagnosed prenatally are often given a message from providers for a variety of reasons, I believe, that is fairly hopeless and fairly dismal. And many of those pregnancies will end in termination. Some will not, but many will. After birth, if a baby is undiagnosed but not diagnosed till after the delivery, what will happen is at 5 or 6 or 7 days of age, a baby is diagnosed. A baby has already had resuscitation procedures, support procedures initiated. So that diagnosis may be given. It is still a challenging diagnosis for families, but families have seen that their child actually is alive and living, and actually that is the case with most of these children when they're born. They do not die at birth, and they will survive, we know now, for fairly significant periods.
If we were to look at a child who has these conditions at birth, what would be the visible signs of such a condition?
They wouldn't always be visible to the untrained eye. They would to some. So some babies may have a cleft lip or a cleft palate. Some babies may have clenching of the hands or the feet. They may have postures that are typical, but some of these babies may not be obviously visible externally. They will have difficulties with development later where someone on the street would walk by and say, well, there's some problem with that child. And some of these children we know now, maybe as many as 10 or 15% are living to 10 years of age.
Which is an extraordinary thing when the prognosis may have been that they would not live much beyond their first birthday.
That is correct. And I think we have learned a lot over the last year. The literature that has come out in big studies, registry studies, and a large center study just released from Canada, Toronto Sick Kids, reports on how the survival is actually much longer for these children if we attempt to support them in some ways than we had previously thought.
Now, you want a change in the attitude to supporting these children. How typically are these children treated at the moment?
Well, I think typically now, for a variety of reasons, Pat, I was trained, and until 2009, I will mark that as my epiphany. I was trained that these children didn't survive and they all died. In 2009, I went to a meeting where I met a number of parents of these children. I didn't realize any of them survived. And it was news to me, and I started looking at the literature. And the literature is clear over the years that maybe as many as even 20 or 30% of these children, or 40%, survive to a year. That 20-30% can survive to 5 years. And I was absolutely puzzled by this, that this was not how I was trained. I think for a variety of reasons, we as medical providers across the board have been a little bit reluctant to accept that these children can live, not because they can't live physiologically, but because they have severe developmental handicaps. And I think it's really more of an issue of us not being willing to embrace the vulnerability and the opportunity, the virtue of dependence that really exists with these children. We all, Pat, are going to leave this life at some point. We are all lethal. We are all temporarily abled. And at some point, we all are going to leave. And I think these children, if we would open our eyes as providers, we would be able to find the love to support them. It would build a community that would flourish.
The question of the quality of life of the child, if as many artificial supports are provided as man can possibly, and indeed woman can possibly survive, that they live on, as you say, some of them up to their 10th birthday. In a way, if what we do at the moment is simply to care for them until they pass away, maybe in their first year, but supporting them until their 10th year, is it almost just delaying the inevitable and putting the parents through 10 years of heartbreak rather than one?
Well, I think what you express is the opinion of many physicians. And I think it's really important that we ask the parents who have these children, if you really want to get that information. Indeed, we have. It's in the literature. It's been well published. These families, none of them, 92% do not regret that they ever made this decision to have this child. In fact, if you ask them, trisomy 18 families and 13 families would, if you had another pregnancy with an 18 or a 13 baby, would you continue it? 82% say they will. 9% say they're unsure. A number of the ones who say they will say, I wouldn't even get tested again. I would have this child. And I think the notion that they're suffering is really a misconstrued notion. I think what happens in my world is severe developmental delay is looked at as a life of suffering. It's not the life that any of us wants, don't get me wrong. And it is a different life. I have a daughter with Down syndrome who's got a developmental quotient that's probably around 40. She's fairly significantly affected by her Down syndrome. She's not suffering. But in fact, many folks would talk about patients like this as suffering. The technology that they require is not generally intensive technology. They do develop to a point of 2 to 3 years of age. Many will require tube feedings. Most don't require respiratory support, though some might. Some might require respiratory support for a period and it's weaned away. So I think when you ask these families, did your child undergo medical procedures? They say yes. 53% say yes, but all say it's enriched their lives and they would never trade this baby.
What ultimately then gives rise to the demise or the death of such a child who has struggled against a lot of adversity to make it to their 10th birthday? What ultimately will take them away?
I think it's a variety of things that potentially can affect them. I think what can't be overlooked is the course of the journey and what this child has met. And we're talking about trisomies, but even if you're talking about anencephaly and children who live much shorter periods, I think trisomy 13 and 18 are very different. As medical ethicist John Lantos, who's one of the world's premier ethicists, just recently commented, Journal of Medical Association, American Medical Association, he said it is untenable at this point that we call these disorders, trisomy 13 and 18, fatal fetal anomalies, lethal malformations, and incompatible with life. That is predicated on the belief, number one, that all of these are uniformly fatal, which if you're living to 10 years, I wouldn't call that uniformly fatal. It may not be the life you want for your child, but these families think think it's a valuable life. Secondly, that the risks versus the burdens are outweighed by the burdens. And these families clearly tell us that is not the case.
They are glad to have known their child for 10 years.
And they have done the care, which they fully recognize is very different than what they thought it would be. I think our goal is to build a society that can help support these folks.
Now, we have a big debate in Ireland about our Eighth Amendment, and there's a movement to repeal the Eighth because it gives the equal right to life to the child in the womb as it does to the mother. And the question of so-called fatal fetal abnormalities frequently comes up. Here we're talking about children who will possibly survive, certainly for weeks, if not months, if not a year, if not 10 years. But do you accept that there are some conditions which, diagnosed in utero, are incompatible with life and are truly fatal fetal abnormalities?
How do you define life?
Well, I'm talking about someone who has no brain, for example, who will never have any cognitive function. And
so you're talking about anencephaly babies. So I think that we don't know a lot about those babies. And if you're talking to me as a medical scientist, what do I think? I think what we realize with those babies, when those babies appear, they are not brain dead. They never qualify as brain dead. These are babies that do many things that normal babies do. Some of them actually try to eat and suck and are able to feed a little bit. So the question becomes, they're not brain dead. Is all of that just reflex, which is the popular thought? And I don't have evidence to totally dispel that. But there is some thought as well that even though you're missing the cerebral hemispheres, there are still neural structures there because all the hemispheres are not equally disappeared in these babies, that there is still some promulgation of some cortical activity. And you see that on pathology specimens when you look at these babies. So there's some element of consciousness there. I think when you talk to families who've had anencephalic babies, and we have looked at this in the U.S., where abortion is readily available in a very open environment, compared women who have had continuation of pregnancy, which those have terminated. And what Duke University has seen is that the women who go on to terminate have much higher scores for grief, much higher scores for depression, and much higher scores for post-traumatic stress syndrome, much higher difficulty coping after the loss of their baby. Universally, in the hundreds of families that I've worked with personally, not with anencephaly necessarily, but with a variety of these life-limiting conditions, I would dispel the language of fatal fetal malformations because honestly, Pat, if a baby is alive for 1 or 2 hours, for the family that had that baby, it was a life.
Yeah. Do you see any circumstance, therefore, in which a termination can be justified?
I'm not here to talk about my personal views about abortion.
No, but I'm just wondering if your medical view is informed by your personal view.
Well, I think there's obviously probably some impact of that, but the medical situation is clear that in the health of the mother, if you're trying to separate out the mother and her ability to cope, it is clear that psychologically and even health-wise, it is better for the mother to continue the pregnancy. That is not popular to talk about, but the medical evidence clearly substantiates that, and I would be happy to come on your show anytime, anywhere, and talk to anyone about evidence that would say, no, it's actually better for a mother in that situation to terminate the pregnancy.
So there is no circumstance in which you believe a termination is justified?
I believe if I am in favor of the health of women, so there isn't a case where I would say it's in your best interest to terminate this baby.
Dr. Marty McCaffrey, a neonatologist visiting from the University of North